So thanks for inviting me. I'm actually going to give a little bit of a primer on genetics and then quickly move into some existing technologies and where we're actually moving towards. And this will lead quite nicely into Tracy's talk, which is going to be about tumor testing. So I have no disclosures. Learning objectives are written here. And they're also on your program. So I will move to the next slide, which is to try to position where hereditary cancer fits. I always like to have this diagram to get the audience into my space because genetics is a large area. So the first is that the majority of cancer patients that you are going to see have sporadic or acquired cancer. And that's where they're actually born with a normal set of genes. And then they get their first hit in life, and that's usually from smoking, alcohol, obesity, hormone replacement, those types of hits that we all think contribute to cancer. And then they get their second hit, which happens later on in life. But both of those hits are isolated to the tumor. And then when you look at the rest of their body, you won't find a mutation. So we use the blood as a representative tissue of the whole body. So when you do a blood test, you won't find it in their blood. In hereditary cancer, that's the minority of cancer patients, the mutation actually occurs in one of three places. It's either inherited from dad, which is a sperm that made you, or it's inherited from mom when she was an egg that made you. Or sometimes when egg and sperm come together, that results in a new mutation, a de novo mutation in the family. And then that results in the first cell, and that results in the embryo. But importantly, as you can see with the green baby has a mutation in the whole body, as opposed to the woman at the top where the green mutation is only in her abdomen or the gynecologic organ. So eventually the same thing happens in the green baby, is that throughout life, something happens from hormones, viruses, obesity, what have you. You're going to get your second hit, but it happens much earlier. And because it's in the whole body, when you test the blood, you will see it in the blood also. But by and large, what happens is that the two hits will be in the tumor. So the therapy of these patients, regardless of how they got their mutations, whether they were born with it or whether they actually acquired it through life, is very similar. So the cancer management is, as you guys know, very similar. So there's some core cancer genetics concepts, so hopefully I'll set the stage up for Tracy, is that tumors are caused by loss of both copies of the tumor suppressor genes. Most cancer is caused by loss of tumor suppressor genes. This principle applies to hereditary cancer and non-hereditary cancer. The tumor contains both the inherited genetic material, because it is part of the body, and also the acquired genetic mutations. So quick lessons on how genes get inactivated. This is the mechanism that most people know how genes get inactivated, in that there is a spelling mistake. If the spelling mistake causes something that truncates the protein, that's caused a stop codon, a nonsense, or a frame shift. The lexicon now is pathogenic variant versus previously we called it a mutation. We're moving away from that because there's a spectrum of genetic variation. So the spectrum is benign, likely benign, uncertain, likely pathogenic, and pathogenic. So one of the ways that mutations cause inactivations is through the stop codon. Another way, a less well-known mechanism, is called copy number variation. So if you want to sound smart to your genetics clinic, is say, did you guys do copy number analysis? Because that is an analysis that most people are not familiar with and account for a good proportion of the mutations. And what copy number analysis is, and if you're able to quote dystrophin, because dystrophin is the classic copy number variant mutation mechanism, is that a whole area of the gene is removed. And sometimes when just reading the spelling, because you have two copies, you cannot see if a whole volume or a whole chapter of a book is removed, because you're reading perhaps the paternal copy when the maternal copy has that genetic change. So this is another way that genes get inactivated. It's called copy number variation. Another way genes get inactivated, particularly of relevance in Lynch syndrome, is called methylation. So methylation is an epigenetic. So we all are familiar with the term epigenetic, but what epigenetic means is that the spelling of the genetic code is the same, but there is something overlying the protection of that spelling that prevents the gene from working properly. That could be protection in the chromatin remodeling. And one of the ways that also happens is called methylation of the DNA. So the DNA is actually methylated, but the actual spelling is still the same. So if the DNA is methylated, then the gene will not get expressed. But when you actually sequence the gene, the sequence will be the same. So it's another way a gene is inactivated and another way that you need to interrogate if a gene is inactivated. And I'll reflect back on this when talking about other disorders such as Lynch syndrome. So this is the spectrum that I was talking about. So there's various types of genetic changes. Those who receive genetic testing reports or genetic consultations from genetics clinic will see different types of lexicon used. So a positive result is usually that a mutation is found. It's very easy for us to make recommendations. We've seen multiple people with this type of genetic change. You should have your ovaries removed, you should have your breast screened, etc. A negative result means that the technology we use didn't pick up a mutation. It actually doesn't mean you don't have a mutation, because a lot of the technology changes and matures, and as our understanding of genetics evolves, we realize a lot of our old technology misses genetic changes. So a lot of the time, simply because somebody had a negative genetic test maybe 5 to 10 years ago, doesn't mean they should not undergo retesting. So we tell our patients who have a negative genetic result to keep in touch with us every 3 to 5 years to get updated genetic testing. Now, as we sequence more people, we are realizing there's a lot of genetic variation between individuals. It may not cause disease. And these are these variants of uncertain significance, where as we sequence more people, we will be able to figure out if these are actually pathogenic or not. There is a certain bar that needs to be met to make the gray a darker color or a lighter color, and that the laboratories are responsible for. So another phenomenon to be aware of is something that's called incomplete penetrance. So incomplete penetrance is defined as the proportion of mutation carriers that have any manifestation of a disease. So if you are a carrier of a genetic change or a pathogenic variant, especially in cancer, it does not mean you're going to get cancer at 100% by and large. This is unlike other disorders like cystic fibrosis. If you have 2 mutations in cystic fibrosis, you're going to get cystic fibrosis. If you have an amplification of a certain size in Huntington's, you're going to get Huntington's, etc. But incomplete penetrance means that you are extremely high risk of developing a certain type of manifestation. So here we have 7 BRCA1 carriers. 2 of them have ovarian cancer. 1 has breast cancer. So the penetrance is 3/7, which is still pretty high compared to the rest of the population. So I'm going to start talking about the disorders and where new genetics is coming in. So hereditary breast and ovarian cancer, this is BRCA1. Everybody knows this quite well in this audience. Here they're at high risk of developing breast, ovarian, and prostate cancer. Their surveillance is that we start breast imaging quite early, and CA-125 and ultrasound do not seem to be effective in this population or in any population. And the management is either prophylactic bilateral salpingo oophorectomy. There we usually recommend after childbearing. Chemoprevention such as tamoxifen has been slightly associated with BRCA1 versus BRCA2. And of course now they are eligible for PARP trials, particularly in ovarian cancer, and also emerging will be breast and prostate cancer. BRCA2 is the sister of BRCA1, also at increased risk of breast, ovarian, and prostate cancer. There's also an increased risk of male breast cancer, melanoma, and the pancreatic cancer risk is slightly higher than compared to BRCA2. What's interesting about these families is that the penetrance is a little bit less than it is in BRCA1. Also, 1 mutation leads to hereditary breast and ovarian cancer. 2 mutations lead to Fanconi anemia, which is a childhood autosomal recessive disorder. So if 2 patients meet each other at a BRCA2 conference, patient support group, and decide to have a child, and that child inherits both BRCA mutations from the parent, that child may have a severe bone marrow failure disorder known as Fanconi anemia. So, when we see a lot of the previvors, Angelina, we may test or do an assessment on Brad, her husband, to give the idea of whether or not Fanconi anemia is possible in that family. So the histologies associated with BRCA1 and 2, this is the big SIMBA study from many years ago. They find that the associated ovarian cancers are generally non-mucinous, not borderline tumors, not non-epithelial. In Ontario, we're moving towards all non-mucinous, as NCCN has, but right now, at least in Ontario, the guidelines say for high-grade serous ovarian cancer. So I wanted to put this into perspective on how somatic, sporadic cancer and hereditary cancer are actually coming together because of the advances in precision cancer medicine. So synthetic lethality is a term that Drosophila geneticists use. I used to be a Drosophila geneticist before I became a human geneticist. So what synthetic lethality actually means is that if you have a line of flies that are fine and are mutated in a gene, and you have another line of flies that are fine and have a mutated gene, it's when you cross them together and then those offspring start to die is the synthetic portion. So what we found in this synthetic lethality and how PARP inhibitors came across is that if when you have a PARP-inhibited line and you also have a BRCA-inhibited line, when you put them together, they actually undergo cell death. And the reason they undergo cell death is BRCA is responsible for homologous recombination. That is the mechanism where the body tries to repair DNA damage. It's a pretty good way of repairing things. But if that is not working properly, as in a BRCA carrier or a BRCA mutated sporadic cell, the cell tries to go through a rescue pathway known as base excision repair, where the PARP enzyme works. So if the PARP enzyme is working properly, the DNA undergoes repair properly. And if the PARP enzyme is not working properly, whether or not you put a PARP inhibitor on, or if it's a Drosophila fly that has PARP knocked out, you're not able to repair the DNA properly, and then the cell undergoes apoptosis. So that's why PARP exquisitely is effective in BRCA-mutated cancers, and that, again, is in BRCA-mutated cancers that arise from a germline mutation, or those patients who develop the BRCA mutations throughout life. So a little bit about old analyses and new analyses when it comes to genetic technologies, especially I'm going to focus on the germline, is back in the day, Sanger sequencing was the way that the human genome was sequenced. And that, I'm quite certain a lot of people learned in biology, where you create some synthetic nucleotide which causes a chain termination. That's what Sanger had developed. And then you get these chromographs, and then you can infer the actual bases by the synthetic nucleotide. So that was the predominant way most people did sequencing. So Sanger sequencing usually cost about $2,000 to $1,000 a gene, which varies depending on the size of the gene and the complexity of the gene and that type of analysis. And at the turn of the century, next generation sequencing happened. So to give you an idea, it cost about $3 billion and 20 years to do the Human Genome Project based on Sanger sequencing. And then next generation sequencing happened, and it costs about $1,000 to do about 20 genes. That's just a ballpark figure. And now it may take about 3 months to do someone's whole genome. So this is mainly because of instruments like the HiSeq from Illumina here that have really altered the way that sequencing is being done at a high level. And because we're able to interrogate a lot of different genes, people have been wondering as well, we know BRCA1 and BRCA2 is involved in the homologous recombination pathway. There are other genes that are involved in that homologous recombination pathway. Are they involved in patients who have hereditary breast and ovarian cancer? What about the patients who don't have BRCA mutations and we think that they have a hereditary reason? So this is a pretty big study with Barb Norquist in Washington, where she looked at, with her colleagues, looked at a number of different histologies, including high-grade serous, endometrioid, and low-grade and mucinous and transitional cells. And you see BRCA1 and BRCA2 are the heavy hitters. But then there are other genes such as BRIP1, PALB2, RAD51C, RAD51D, and the Lynch syndrome genes also through this type of analysis of doing multiple different genes at the same time in these types of patients. So this is moving into the clinical realm. Very few laboratories these days are only doing Sanger sequencing on BRCA1 and BRCA2. And when this came about back in 2013 and 2014, when mainly the push from the lab is that Myriad no longer had their patent in the States, so a lot of genetic testing companies moved into the cancer space where they were in other disorders such as pediatric, neurologic, and cardiac. So when that patent was lifted, everybody moved towards cancer panels, and cancer panels were being offered in a widespread basis. But really, we didn't know what to do with a lot of these genes. But thankfully, about 3 to 4 years later, Nadine Tung and a large group had come together to decide how to manage these genes. So these genes, aside from BRCA1 and BRCA2 and maybe PALB2, are all low penetrant genes or moderately penetrant genes. BRCA1 and BRCA2 and Lynch syndrome are highly penetrant. So now we're moving into panel testing where a lot of these genes, the clinical relevance of them is coming into question. So something like ATM, except for one mutation specifically, it's mainly a breast cancer gene. There's some literature that says that it's associated with pancreatic cancer, but from a practical perspective, to manage these patients, you usually start breast screening, but not as early as the BRCA carriers because the penetrance is lower. We start at the age of 40, and we just add a breast MRI. Same thing with CHEK2 NBN. PALB2 is a little bit more highly penetrant, not quite as it is for BRCA1 and 2. And relevant for this audience is BRIP1, RAD51C, and RAD51D. They're involved in the Fanconi anemia pathway. They are at an increased risk of developing ovarian cancer. Hasn't quite yet been quantified, maybe 2 times population, 3 times population, not quite as high as BRCA1 and 2. There, we recommend the oophorectomy occur after menopause, not after childbearing. But by and large, because these genes are so very rare, just to give you an idea, BRCA1 and BRCA2 is about 1 in 500 people, or 1 in 800. These are in the 1 in 10,000, 20,000 range. So in order for us to have any sort of evidence to this is quite challenging, and the genetics community is trying to gather these patients in a systematic way. I want to talk a little bit about Lynch syndrome and tie in some of the genetic technologies we use in the workup of Lynch syndrome. So Lynch syndrome is a hereditary colorectal cancer disorder. Gynecologically, it primarily manifests with endometrial adenocarcinoma and ovarian cancer, endometrioid and clear cell being the predominant histologic features. We learned in medical school that if they have Amsterdam criteria, where 3 individuals in the family are affected with core Lynch cancer, 2 of them are first-degree relatives, 1 of them is under 50 years of age, you should consider Lynch syndrome. This is a very complicated, difficult thing even for the genetics clinic to keep track of. And we're moving away from that, and a lot of efforts are moving towards endometrial cancers. In NCCN, they state that all colorectals under 70 should have immunohistochemistry to rule out Lynch syndrome. And the same thing at our center, a lot of the women with endometrial cancer are being screened immunohistochemically for Lynch syndrome. The management there is generally colonoscopy, consider endometrial surveillance, and risk-reducing salpingo oophorectomy. So immunohistochemistry looks at the proteins. So a lot of the times a negative test is good in medicine. Your CT scan was negative. But in immunohistochemistry, if it's negative, it's actually bad, meaning that the protein is not working properly. So just be careful when you're reading the histology reports. Depending on where the immunohistochemistry is done, it may say immunohistochemistry for Lynch syndrome was negative and staining was positive for the proteins. So there needs to be a little bit of standardization within some of the reports, so just be careful. Positive or expressed means good, that the gene is working. Negative, immunodeficient, means that it's not working and it's not being expressed. So how do these genes not get expressed? One of the ways it doesn't get expressed in the tumor would be is that, of course, you have a mutation. You are born with Lynch syndrome and you have it. So one of those 4 genes that I talked about in mismatch, MSH1, MSH2, MLH1, MSH2, MSH6, and PMS2 are responsible for mismatch repair. One of the genes that I wanted to talk to you about is EpCAM. So the way EpCAM works is that EpCAM is not involved in mismatch repair at all. It's a cell-cell adhesion molecule, but it's adjacent to MSH2. So when you delete a portion of EpCAM, that causes an epigenetic change on MSH2's promoter, which prevents MSH2 from being expressed. So essentially, a nearby mutation of the MSH2 gene causes a functional mutation that the MSH2 protein is not being expressed. So it's an epigenetic mutation. Now, what does microsatellite instability mean? So microsatellites, I'm not too sure if many people in the audience know that we really don't use microsatellites in medical genetics. Does anybody know where microsatellites are used? So microsatellites are generally used and mini satellites are generally areas of the genomes that are repeated. And this is what forensics use to identify the murderer in cases is that microsatellites are polymorphic, meaning that they are variable between 2 individuals at a high rate. Evolutionary, that seems to be why that happened. And because they're so variable between 2 individuals, no 2 individuals on this earth will have exactly the same number of microsatellites to a certain statistical significance. Now, what does microsatellites have to do with Lynch syndrome? So microsatellites are regions in the genome that are highly variable, but you are born with a certain number, because that's who you are. So if you committed a crime, people could identify you based on your microsatellites. But in Lynch syndrome, microsatellites are generally repaired by this mismatch repair mechanism. So when you look inside of a tumor, they start to expand because they are not being repaired properly. And that's what the microsatellite instability assay is doing in the tumor, seeing if the microsatellites, if you are a normal person, you have a certain number at BAT25. That's your, modus operandi if you were a murderer. This is the number of microsatellites you have. In the tumor, your microsatellites expand and contract because your mismatch repair is not working properly. So you have a variable number of microsatellites. So that's what the microsatellites are actually looking inside the tumor. So how does this relate to, and I wanted to bring this back to how this is related to the understanding of the management of Lynch syndrome. I'm sure a lot of you know that Lynch syndrome and mismatch deficient tumors are exquisitely responsive to immunotherapy. So in mismatch repair deficient tumors, whether it be a Lynch syndrome or whether it be a sporadic tumor, what we have is a mismatch repair problem. And when mismatch repair happens, you get mutations throughout the cell, and that causes cancer. But what that also causes is lots of foreign proteins to be expressed. And these foreign proteins that get expressed are expressed on major histocompatibility complexes, or MHCs, and the T cell receptor tries to match it and will recognize it as foreign. But the tumor cells have increased PDL ligand to prevent the T cell to recognize it. So that's the way the tumor has evaded this. And that's why if you add PD-L1 inhibitors or PD-1 inhibitors to the chemotherapeutic regimen, that these mismatch deficient cells that are producing all these aberrant proteins outside of the cell on their major histocompatibility complex are ready to be lysed by the T cell. So that's why immunotherapy seems to work well in these types of tumors, whether it be an inherited reason or whether it be a sporadic reason. So a lot of the times we get some questions. We have an immunodeficient tumor, or the proteins are not working properly, and we do germline testing for the genes, and they don't have a mutation. One of it, like I said, is if a genetic test is negative, it could be that we missed the mutation. The technology is not adequate. But we still have this immunodeficient tumor in the pathology report. And how do we explain it if it's not because of an inherited mutation? One of the things that we do is we look at MLH1 methylation. So MLH1 methylation occurs by and large in sporadic tumors. Usually there are some exceptions, but usually you don't inherit a methylated MLH1 from your parents. That doesn't cause Lynch syndrome. So if you were to look in the tumor and you find MLH1 methylation, that is your explanation on why you have loss of MLH1 protein expression in the tumor, and that means you don't have Lynch syndrome. So a lot of the times when patients are assessed, you have an immunodeficient tumor in MLH1, you look at MLH1 in the germline, it's normal. Where is that protein? Why is that protein in the tumor not being expressed? We go back to the tumor and look at MLH1, and if MLH1 is methylated, that's usually a sporadic, non-inherited events that are exclusive to the tumor, and we rule out Lynch syndrome and say this is a sporadic event. The methylation occurred from smoking, obesity, what have you, hormone. Another tumor-specific event that doesn't happen in Lynch syndrome is V600E and BRAF. That's another way we look at the tumor. If we look at the tumor and see V600E, that tells us that it's probably not Lynch syndrome, because in Lynch syndrome patients, when we look at them, we don't see V600E. So MLH1 methylation and V600E in the tumor generally rules out Lynch syndrome. Sometimes we still have an immunodeficient tumor in MLH1. We look at methylation in the tumor, it's normal. We look at V600E, it's not there. So did we miss something in the blood? So what we actually do now is this is the principle of looking in the tumor. So all tumors will have loss of their tumor suppressor genes. So if you look inside the tumor of a person who has cancer, you're going to expect to find 2 hits in the tumor. In a patient who has Lynch syndrome, in a patient who has sporadic cancer, and we look inside of their tumor, and you see 2 mutations in the tumor that you could not detect in the blood, that means that those 2 mutations in the tumor occurred during life. They weren't born with it. And that person does not have Lynch syndrome. So that's where we use analysis of the tumor to rule out Lynch syndrome in an individual. Because you still have that immunodeficient tumor, you need to find an explanation for it. You didn't find it in the germline. Why is that protein not being expressed? That protein is not being expressed because you acquired 2 different MLH1 mutations that we didn't detect in the blood. And because we looked in your blood, it only happened throughout life. Are people following me here? So it's 2 mutations in the blood, in the tumor, that you don't detect in the blood. Sometimes we get these results. Sometimes they help us solve these cases entirely. We find 2 smoking guns in the tumor. We didn't find it in the blood. That explains their immunodeficiency. Their family is not at risk. So we can say no colonoscopies for your family. Sometimes we still have an immunodeficient tumor. We look in the blood, we didn't find anything. We look in the tumor, we didn't find anything. So there it's a little bit more challenging. So this is where everything in hereditary cancer is actually moving towards. It's tumor sequencing, because tumor contains your germline, your inherited genome, and your acquired somatic genome. And there was just a recent paper by Heather Hampel and the Washington group saying that they did this on Lynch syndrome. Instead of doing the routine immunohistochemistry, MLH1, it's very confusing even for me to keep track of all of these things in tumor testing, germline testing, hereditary versus non-hereditary. And then you have to be aware of all these different genes. Is that what they actually did is that they just sequenced the tumor. And based on what they saw in the tumor, were able to exclude or include a possibility of Lynch syndrome. So what they did is they did upfront tumor sequencing in colorectal cancer, and they found it had superior sensitivity than the current convoluted way that we do it right now by doing immunohistochemistry, then germline testing, then tumor testing, et cetera. As they say that just do NGS on the tumor, and this is becoming an economic reality right now. And this may be where ovarian cancer will be moving, and endometrial cancer may be moving in Lynch syndrome. So I talked a little bit about Lynch syndrome and the complexities and the genetic types of technologies that are used there. This is just another syndrome that I wanted the audience to be aware of because they get rare types of gynecologic tumors known as embryonal rhabdomyosarcoma of the cervix and ovarian sertoli-related tumors. The surveillance in these patients is very undefined, and they're at risk of developing mainly pediatric tumors. And why did I put this up here? It's not really a new genetic technology, but it's a new type of genetic phenomenon because Dicer is involved in a new genetic species known as microRNA. So microRNA or inhibiting RNA are involved in RNA processing and gene regulation. It's a new way that genes are being regulated, and it's called Dicer predisposition syndrome. So I'm going to take the next half to talk a little bit about genetic counseling and why genetic counseling and the genetics clinics are important and how we can work together. Some advances in genetic testing is that there is now a new insurance policy in Canada known as Bill S-201, where companies are not allowed to ask about genetic testing results when you apply for insurance. However, they still can ask about family history. So if you have a strong family history of breast ovarian cancer and you tested negative for the BRCA mutation, the insurance company will not be able to adjust your premium that way. So it still needs a little bit of fine-tuning. So one of the things that the genetics clinic is very good at doing is following family members. So most patients that you will see have cancer, but they will have daughters, and they will have daughters that wish not to pass on their genetic mutation to their family members. This is a rather old genetic type of technology known as chorionic villus sampling. We can do that at about 10 weeks of age right now. The risk of miscarriage is slightly higher, but it can be done if we find the specific genetic change in the family. And pre-implantation genetic diagnosis is getting better and better and better. Still, we need the parents to develop an appropriate probe, but a lot of families, particularly I'm seeing with Lynch syndrome, choose to undergo pre-implantation genetic diagnoses. And another driving force is that I believe one round of PGD is covered by the provincial healthcare system, at least in Ontario. And a lot of drug companies are funding the medications for ovulation. So these are kind of old genetic technologies that are getting better, better, better all the time. But I'm going to talk to you very briefly about some new genetic technologies. And we've been talking about panel testing and massively parallel sequencing, and now everybody is moving to whole genome sequencing and exome sequencing. So exome examines all 30,000 different genes in the human body, just the coding regions, which are called the exons. To give you an idea, that accounts for about 1% of the whole genome. 99% of the whole genome is generally non-coding, and we actually don't know what they do. It's called the dark genome. So a lot of studies are coming out in pediatric cancers where they're doing whole exome sequencing and looking at the diagnostic yield on these patients and sequencing their germline and the genome. So what we find is that when you look at whole genome sequencing in the tumor and the parent, so here they looked at the father's exome, the brother's exome, the mother's exome, the proband's exome, which is the person who had the cancer, and they looked at the tumor and they looked at the RNA. Out comes crashing out a p53 mutation, saying that this p53 mutation is causing this patient's cancer. But the main problem here is the bioinformatics. It takes it's terabytes of information to filter through, and the limiting factor is time. And there are some policies, if you're going to be looking at all 30,000 different genes, there are some medically actionable variants that we do need to return back to patients. They include the cancer genes, the cardiomyopathy genes, and some metabolic disorders that the medical genetics community has said we need to give these back to the patients when we're going to examine everything. We're not going to give them carriers for some rare metabolic disorder. My last few slides are going to talk about circulating DNA. So this is Eunice Lee. She is, I'm sure a lot of you in the audience know what NIPT is. So NIPT is a non-invasive prenatal testing where you look at the plasma of mothers who have babies who could be at risk of Down syndrome. and you are able to detect the extra 21st chromosome in the plasma. So Eunice Lee is a 40-year-old anesthesiologist, and because of her late maternal age, was at risk of developing a baby with Down syndrome. So she had NIPT, which was positive. So she had an extra piece of 21 chromosome floating around in the body. They did an amniocentesis, and her baby does not have Down syndrome. So where is this extra piece of 21 coming from? It's actually she had a rectal tumor that was secreting the tumor DNA. So this is where, so there's a big paper in JAMA saying that NIPT is picking up cancers in pregnant women. And now this is what liquid biopsy is, and how we in the cancer community are exploiting this technology to look to see if there are tumor-specific events that we can pick up in the plasma. And this has becoming so sophisticated that we think we can look for recurrence, minimal residual disease. It's mainly in the lung cancer field right now. It will move into the gynecologic field. Methylation changes are genetic alterations that we discussed, but actually there are methylation signatures that can tell you where in the body this tumor is coming from. And on top of that, coupled with the mutational profile, hopefully we'll be able to use a blood test to detect cancers. So with that, I will close. I will take any questions.
Do we have questions in the audience? So,
I know that every province differs in their approach, but are clinicians allowed to order genetic testing on patients, for instance, gynecologists on ovarian cancer patients in Ontario?
Yeah, so in Ontario, we're moving to this movement. It's called mainstreaming, and we're trying to implement this across Canada. And at least in Ontario, any clinician can order genetic testing. So we can't deal with the demand. So at least in our MedOnc clinic, we've empowered the medical oncologist to order genetic testing. And now we're moving it over to the gynecologic surgeon clinic. There was a big paper in JCO 2 months ago about the Embrace study, and they actually are doing the same thing for ovarian cancer patients. And this needs to happen is that the oncology community needs to be comfortable with ordering genetic testing because they can't wait to see the genetics clinics. There's only so many of us. So we're part of that movement, and we're doing that at least in Ontario, and I know BC is doing it, and Calgary is. So yes, speak to your local genetics clinic, and they'll teach you how to order it.
and what is your average time from ordering the test to getting the diagnosis back to the patient?
So if you see a patient today and you order the blood test, the actual turnaround time of genetic testing should be between 6 to 8 weeks. In the breast scenario, we can try to get BRCA1 and P53 within 2 weeks. We push our lab to do that because it makes a difference in surgical management. By and large, it takes about 4 to 6 weeks. It's not bad, but it's the wait to get to the genetics clinic that's really long. And we're trying to, in order to bypass that, if oncologists order it in conjunction with the genetics clinic, I think it would be much more streamlined.